Hey guys, am I audible and visible? A very good evening. Hope I'm audible and visible. If so, say me and hi. Hello, how are you doing? So today we're going to start the one shot of pathology. So we'll be having one shot for every chapter. I'll tell you first the objective of what we are going to do with one shot and why it is essential for a student. I'm audible and visible. Sorry, why it's essential for a student who's sitting for the exam, be it an internal assessment, be it your college, university exam, whatever it is. See, we had completed quite a few hardcore concepts for you to master in history batch. And most of the students said that your internal assessment is coming. You're not able to kind of take it to the next level, not able to write answers. Sometimes we had some difficulties. The exam pattern keeps on changing, right? The newest headache most of you guys have is reasoning questions. How many of you find reasoning questions to be difficult? Is it difficult? Is it easy? How is it? But sometimes looks difficult, right? It's not difficult exactly, but look and the feel and the tag of reasoning, right, for 3 marks might look difficult, right? So the entire sole objective of this one shot for every chapter is I'll be concentrating on few reasoning questions, which might definitely be playing an important role in every internal assessment in your university exams with respect to chapters. We'll go with few clinical scenarios. Though we know each and everything about the metaplasia, be it the pathogenesis, be it the etiology, be it the mechanism, be it the microscopy, if it's given in a LAQ, how do I detect that? Okay, this is the history. This might be the most common answer diagnosis that we'll see, and few untouched topics. It's not a clearly untouched topic, but there are few overlapping things. Your university exam asks like purely write a short note on gangrenous necrosis. We had covered them in necrosis, but not separately gangrenous necrosis, right? So that we'll see, and also we'll see a few important topics. We'll quickly revisit, right? So this is primarily for students who are sitting for the university exam. If you feel that you need an extra push, this will be the go-to place, right? So that note, let's start. I want you guys to be a little bit more interactive. More you answer, more questions I can. You ask more answers or reasons I can give that might come in a university exam. Fine. Hello, Fakti. Good evening. So, is the first reasoning why question. Why do you think skeletal muscle undergoes hypertrophy and not hyperplasia? Okay. I'm just created a few list of reasoning questions. There are like 7 or 8 of them. So if it comes in the exam, it might be helpful for you. The only thing here is most of the reasoning questions can be reasoned out in a single line. They ask you to write it for 3 marks. 3 marks, it's a little bit less to write in any reasoning questions. Some of the students shared the paper, internal assessment paper, which came in their college. It's difficult, right? But still, I can give a brief idea of how to write, right? The answer is pretty simple. Like Fakti said that a skeletal muscle cannot divide. So how do I kind of make it a little bit lengthy so it looks okay for a 3 mark answer, right? So first you write the concept of hyperplasia. Hyperplasia is equivalent to cell division, right? So that's what hyperplasia is. So when you have a cell division, by default, any dividing cell can undergo hyperplasia. So we have clearly made the premise that any dividing cell can undergo hyperplasia. That's the first thing. Now, if that is true, which takes to my next answer, skeletal muscle mostly, right? Like it's kind of a permanently differentiated cell, though not exactly permanently differentiated cell. It's kind of a permanently differentiated cell. Skeletal muscle, though there are evidences that there are something called satellite cells in some cells, they have very less capacity to divide, or literally no capacity to divide, right? So since they don't have the capacity to divide, so they can't undergo hyperplasia. So they predominantly undergo hypertrophy, right? It's a single line answer. Like Fakti said, it cannot divide, right? Perfect, Fakti. So that is unfortunately the reason, because most of the reasoning questions have one answer. That's all. That should be enough. But I don't know if your examiners will be open to giving you marks if you just write skeletal muscle is not the capacity to divide, so they cannot undergo hyperplasia. That's all. As simple as that. If I am the examiner, I'll give you full marks because you have answered what is required for. But unfortunately, some people still want the pages to be covered. We also kind of look inferior, no? If I write one line for a 3 mark question, what will happen? For that, stretch it. You know the basic premise of how to stretch and write. Stretch it, write it. But the answer is skeletal muscle do not have the capacity to divide, so they don't undergo hyperplasia. If this question comes in a viva, they might ask you, does it mean that skeletal muscle does not have stem cells? There are evidences that there are cells called as satellite cells. Okay, these are people who are aiming for a honors or distinction. They are there, but they don't have the exact capacity to completely regenerate. Satellite cells are that helps it, right? Perfect. Crazy loser. I can change the question like whatever crazy loser asked. Why don't neurons undergo hyperplasia? Because they don't divide. That's all, right? So next question. Okay. Let's see how many of you can give the answer. More you guys comment, more you guys ask questions, more I'll be able to share the knowledge with you, right? Why does chronic uterine estrogen exposure cause endometrial hyperplasia? What do you guys think? What is the answer? Why does chronic uterine exposure, estrogen exposure causes endometrial hyperplasia? You guys know the answer, right? It's simple. If I have to give a one-line answer, estrogen is a growth factor for an endometrial glandular cells. So when there is more estrogen, obviously there will be more response to the growth factor, which causes endometrial hyperplasia. That's all, right? So how do I write? So it's estrogen. So estrogen effect on normal endometrium. First, we'll have to write on it. So in normal endometrium, estrogen will help in the division or increase in the proliferation of glands, okay, which we already know, right? Proliferation of glands in the glandular phase of menstrual cycle. During menstrual cycle, we have that, right? So in other words, if there's any cause with an excess estrogen, the cell division will be more. Since the growth factor, I'm writing GF for growth factor, this automatically will be increased in cell division. When there's an increased cell division, which automatically increases nothing but a hyperplasia, right? It's simple. Why is estrogen causing it? Because estrogen is going to help in that, right? Crazy news, I won't. Yeah, it's the estrogen acting on its receptor causing the growth. Yeah, you're right, right? So that's how the estrogen has an impact or plays an important pathogenic role in case of an endometrial hyperplasia, in case with hyperestrogenism. If you feel that you want to write a little bit more, you can add on to few causes of hyperestrogenism, which you may have read in the lectures, your PCOD, your granulosa cell tumor, your obesity, all of them can also contribute to the hyperestrogenism, right? Perfect. Next, this is actually a word from Robbins. Can anyone tell me why metaplasia is considered a double-edged sword? This is there in Robbins. In one of the lines, it will be written that metaplasia is a double-edged sword. Why? Reasoning questions come like that, right? Even in your school days, you must have read about assertion reasoning questions in your NEET, UG and everything. Same way. Why is metaplasia a double-edged sword? A double-edged sword ka matlab it's both useful sometimes it might even prick us. It's a bit dangerous as well, right? So first of all, for me to call it a double-edged sword, I want you not to write only the bad thing of it, which is becoming a cancer. That by default is true. It's double-edged, right? So for me, metaplasia is definitely an adaptation, okay, which helps to survive in difficult conditions. But unfortunately, since metaplasia during adaptation, the mechanism of metaplasia, which is very, very important, is to reprogram the stem cell. I'm going to reprogram stem cell. This is the primary mechanism of metaplasia. There are other mechanisms of metaplasia also. Since I'm touching or reprogramming the stem cell, this can trigger and there's an increased risk of mutations, which can definitely cause your increased risk of cancer. Okay, I want in your answer sheet this word. It's going to reprogram stem cells, because anything which stem cells, anything which is going to cause problems in stem cells can definitely increase risk of cancer. Metaplasia is good as a cellular adaptation, but if the stimulus persists, and this happens only when there's a persistent stimuli. If the stimulus is gone, no issues at all, right? If it's a persisting stimuli, automatically it's going to cause or increase the risk of mutation and increase the risk of cancer formation. Fine, done. Perfect. Next, can anyone tell me the answer? This is a very simple question. Why does ischemia cause lactic acidosis? Yes, crazy loser. I think when you go to systemic pathology and hematology, there'll be much more superb questions of why and reasoning. But here they are very simple basic questions. Why does ischemia cause lactic acidosis? This is actually something combining your biochemistry, what you read in your first year, and also the pathology, right? So it's simple answer. In case of ischemia, when I'm sure you know what is an ischemia. Ischemia is equivalent to loss of blood supply or reduced blood supply, right? So whenever there is reduced blood supply, by default you'll have reduced oxygen. Whenever there is reduced oxygen, by default you'll have reduced aerobic glycolysis. But still, blood sugar is there, right? It's not zero blood supply, reduced blood supply, right? So I have reduced aerobic glycolysis, and once it has reduced aerobic glycolysis, it automatically goes to your anaerobic glycolysis. When it goes to anaerobic glycolysis, and it is going to increase the accumulation, the end product of anaerobic glycolysis is lactic acid, that increases. That reduces the pH, that causes lactic acidosis, that even might precipitate the protein or destroy the protein, right? Not muscle alone, anything is going to be anaerobic respiration, anaerobic glycolysis, that automatically increases your lactic acid level, which causes lactic acidosis, right? So it's an indirect link. Like I said in the start, Most of them have a single line answer. You should know, like Factor said, the art of explaining it and making it a little bit longer, right? Okay, this question. This is a question, this actually is a doubt for many of the students. I keep on getting this almost same doubt in most of the lectures, like why does this happen? Maybe we are not very clear. Now I'll take it as a separate question and read it in detail. Why does coagulative necrosis preserve tissue architecture and liquefactive necrosis does not preserve tissue architecture? This is an important question. Okay, so what happens in coagulative necrosis? It's simple. In coagulative necrosis, the main mechanism of action is protein degradation. Okay. So this is the main mechanism of action of coagulative necrosis. When I take protein degradation as the main mechanism of action, there are multiple types of protein in my body. I have functional proteins, I have structural proteins. Hemoglobin, globin is a protein, right? Cytokeratin, skin has protein. Hair, keratin has protein. There are multiple forms of protein. If coagulation of the protein is the most important thing, crazy loose cell membrane, I would say not preserved, cell architecture is preserved, right? So this protein degradation automatically will destroy both the proteins, both the structural proteins as well as the functional proteins of enzymes, right? But unfortunately, the structural proteins are a little bit more stronger compared to the functional proteins. I'll tell you why this is required. Okay, they are stronger compared to the functional proteins or compared to enzymes. This word has to be there, okay, because enzyme is also a protein. Let's say I have an enzyme which is a protein. Even tiny alteration in the structure will destroy it, like quaternary tertiary structure will destroy it. But a structural protein is a little bit firm, little bit stable, they are a little bit more stronger, right? So what happens is, when protein degradation is the main cause, this automatically or indirectly will cause enzyme inactivation, right? If there's an enzyme inactivation, this will actually preserve the background parenchyma. It will be preserving. Once the background parenchyma is preserved, automatically the shape or the architecture remains, right? Because of this reason only, the architecture remains intact and you will have ghost cells as well. The simplest answer will be, like you guys said, it's a coagulation of protein being the mechanism of action. It will destroy the structural proteins a little bit later. That's why the structure remains a little bit later compared to the function, which will be destroyed a bit earlier. So the cell dies, but the structure remains because the architecture does not collapse. On the other hand, if the same question is like, why does liquefactive necrosis does not have an architectural loss? Answer simple. Liquefaction, the mechanism of action is activation of enzymes. It activates the enzymes. That's the primary mechanism of action, right? So if the enzymes are going to be activated in the first itself, it's going to definitely destroy the parenchyma more. It's not prevent, it will destroy it more. Once it's destroyed, I'm going to end up in having the same problem of the architecture being lost. Okay, fine, done. Next, this is also an indirect question to whatever we discussed now. Why liquefactive necrosis is common in brain infarcts? We have discussed that in the class as well. Can anyone answer why? Simple, right? So brain, basically the brain parenchyma is made of lots and lots and lots of lipid. So once the brain parenchyma is made of lipid, what it happens, it automatically is going to require an enzyme activation. The enzyme activated will be your lipase. One of the enzymes activated will be lipase. This lipase is going to destroy the brain parenchyma. Once it destroys brain parenchyma, the parenchyma is gone, so automatically it will liquefy. Liquefaction is, it's a fat liquefying, like a butter becoming a ghee. That's what happens primarily to the brain when it's getting infarcted, right? Perfect. It's primarily the enzyme activation, primarily lipase activation, along with many other things which will destroy the brain parenchyma, make it like a liquid once it's going to die. This is the basic concept of liquefactive necrosis, right? Next question. We already know the statement, right? Why does apoptosis does not cause inflammation? We know that it doesn't cause inflammation. The answer question is why. Hi Allah, hope you're doing good. I'm great. Why apoptosis does not cause inflammation? We know it does not cause inflammation. The answer is why. It's a simple question. Why it does not cause inflammation? Very, very easy and simple. In apoptosis, what happens, the most important thing is this word. If this word is there, that's more than enough. You have an intact cell membrane. The moment I have an intact cell membrane, automatically there is no intracellular, IC's intracellular content leak. When there is no intracellular content leak, there is no trigger for inflammation. That's why apoptosis does not have inflammation. Okay, intracellular contents, once it leaks, automatically my body will respond to it, will cause inflammation. Here there's no trigger for inflammation. That's why we don't have that, right? In addition to that, if you want to add a little bit more, this word is also important. In apoptosis, the apoptotic bodies, right, AB is for apoptotic body, is removed by a process called as an efferocytosis. Efferocytosis is a very swift phagocytosis. So it doesn't wait for the inflammatory cells to come inside. Fine. Ahmad, the fatty change is reversible, and if the cell is alive, it can definitely die at a later point of time, right? It is not that it will not die at a later point of time. Reversible ka matlab, it's simple. So I have a cell where there's a problem. It has a fatty change because of whatever reason it is, right? And if this stimulus is removed, it will come back to normal. If the stimulus is persisting, it will become irreversible. It will die. That's what reversible, right? Okay, done. See, it can come back, it can go beyond a limit. When I damage mitochondria as well as when I damage the cell membrane, it will become irreversible. Fine. Hello, Aniket. Good evening. Then the last reasoning question for you: why does cellular aging involve telomere shortening? That's the basic thing what you must have read in your biochemistry, right? Telomere shortening is a way to age. That's all. So whenever there is a cell division, if you want to make it bigger like the Okazaki fragments and everything, but I don't think that's required much. Most of the pathologists might have forgotten Okazaki fragments, so don't make us read more, right? Whenever there's a cellular division, automatically what happens? The terminal edge of the DNA will be lost, right? The terminal end, which we call it a telomere, telomere will have no complementary basis. Okay, because of no complementary basis, automatically it will be lost or it will be destroyed. So with repeated division, right? Okay, with repeated cell division of any cell for that matter, automatically it goes beyond a certain limit. There's a threshold limit. If it shortens beyond the threshold, the cell cannot survive. Like crazy Loser said, the most important genetic information will be lost when it's going beyond the threshold. It doesn't survive, it'll automatically die. And when these cells die, overall the function of the organ or the tissue reduces. That results in cell aging, right? Here the cell dies. Because of that, there's a reduction in function of the organ or tissue. That results in aging. Aging is a permanent reduction in the function and the structure of an organ or a tissue, right? Ahmad, I'm not able to understand. Can you rephrase your question a little bit more? See, apoptosis is different, necrosis is different. What tells me to undergo apoptosis or necrosis? What is the trigger? Like for example, I have a DNA mutation, it predominantly goes to apoptosis. When I have an intracellular protein accumulation, it predominantly goes to apoptosis. Physiologically, everything predominantly goes to apoptosis. When it's hypoxia related, it predominantly goes to necrosis, right? So the pathways are different. It's the same mechanism. Its endpoint is death. The pathways are different, right? So if a person is going to shoot, it'll have gunshot, it'll have a hole, it'll have splatter of blood. Versus stabbing, it'll have its own hallmark, right? So I cannot ask why a stabbing person is not having a gunshot wound, right? So this is different, that's different. If you can help me to clear your confusion, I'll maybe help you to answer it better. Fine. Okay, done. So these are few reasoning questions which I can think of which can be asked in the first chapter of cell engineering adaptation. We'll go like 7 or 8 every chapter. So cumulatively in the general pathology, you'll have some 50, 60 questions on reasoning why. I think that's a good enough resource to start. In addition to that, you have a group when any of your internal assessment exam goes through, send the reasoning questions to me. I'll compile it as a PDF and send it back to you guys, because that's very, very important, so that over the period of time when you come to university exam, we'll have a good amount of solid content for you for your university exam, not like the last year. Fine. Okay, great, Ahmad. Perfect. Now let's go to a few short notes which you guys asked. One of the important questions, like, let's talk about gangrenous, because you've been asked about gangrene in your theory, in your practicals, in your viva. When there's a sample of gangrene in front of you, you've been asked about gangrene. I'm not able to write about gangrene. Though we have discussed about gangrene, we have not formulated something for gangrene. That's what we're going to do here, right? If a question comes on gangrenous necrosis, please don't confuse. First, as usual, the structure. Write a definition of gangrene. Gangrene is a clinico-pathological term, whereas in extensive tissue necrosis, this is very, very important. I'll tell you exactly what this means. With or without superadded infarction, most commonly in the extremities. Viscera also it can happen. I can have a small intestinal gangrene. I can have an intestinal gangrene, right? Due to ischemia or infarction, right? So now this term, like I said, is very, very important. With or without superadded infarction, right? Infarction is not the problem. Superadded infarction is the problem. Every gangrenous tissue will have bacteria. Doesn't mean it's a superadded infarction, right? I'll give you a simple example. Let's say leaf gangrene. I'm going to take a bit of my tissue and put it outside without blood supply. Will bacteria grow on it? It will grow. Or simple banana. When you have a banana, the black area in the banana is where the bacteria grows. Leave the banana for quite some time. The amount of bacteria in the banana keeps on dividing more and more and more and makes the banana liquid. That's different. That's the difference between dry and a wet gangrene, right? As simple as that. Maybe you must have, you can relate easily with the banana example than with the human life, because you must have not seen it. Once you go to final year, you will definitely see classical types of gangrene. Both of them will have infarction. One is more superadded, one is without superadded, right? Perfect. Types of gangrene, like Crazy Lucy said, I have two types, and I'm sure you guys must have known about this by this time: dry gangrene and wet gangrene. Don't ask me in between what will happen. In between there will be an overlap, but we need not distinct it and delineate it and learn about that. Fine. Okay, same Ahmad. Reversible is a process, right? Let's say a person smokes. There'll be a change in the epithelium first, that we call it metaplasia. The person stops smoking, it will come back to normal. If the person continues to smoking, it will not become reversible. It will become dysplastic, it will become carcinomatous, which is irreversible, right? And it's a process. Once the stimulus stops, it's reversible. Otherwise, it's not reversible automatically. Fine. So what's the difference between dry gangrene and wet gangrene? Dry gangrene, as simple as wet gangrene is with superadded infarction. Dry gangrene is without superadded infarction. That's all. Microscopy changes, mechanism changes a little bit. We're going to look at each of them, right? So gangrene in general can have mostly overlapping etiology. Dry as well as wet. For example, let's say diabetes can cause dry gangrene, diabetes can cause wet gangrene. Atherosclerosis can cause dry gangrene, wet gangrene, right? Peripheral arterial disease also due to atherosclerosis can cause dry, wet, right? But few things which is important for wet gangrene is these two. Whenever you have a trauma with contamination and diabetes, are very easy to form a wet gangrene compared to the atherosclerosis. If you look at both of them, right? If you look at both of them, here generally the process slow. Here generally the process fast. If you have a very fast process, it happens, fine. I'll do it crazy. Just give me a second. If it's a very fast process, generally it goes to wet gangrene because my body is not getting enough time for it to adapt and change. If it's a slow process, maybe like slowly it's dying. Some bacteria came. My WBC came and killed it. Again, slowly dying. Bacteria came. WBC came and killed it. Suddenly dead. Bacteria came. No one to protect. Definitely superadded infection will be there by default. Fine. Okay. Coming back to your question. Gangrene is a term. Whenever you see something black in color in naked eye, I call it gangrene. It's a clinical term actually. I also has a pathological impact. That's why it's a clinico-pathological term where you have extensive tissue necrosis seen by discoloration with or without superadded infarction. Most probably in extremities, can also be in the intestine, can also be in the internal organs due to ischemia or due to less blood supply. Fine. Which part is confusing, crazy loser? Let me know. I'll answer that. Okay. Fine. So if it's slow, probability of it becoming a dry gangrene is more. If it's fast, probability of it becoming a wet gangrene is more, right? The most important term is this. There's no putrefaction or there's no superadded infarction. Infarction will be there. I don't have a superadded infection. Here, I'll have ischemia and always superadded, predominantly superadded bacterial infection only, right? So whenever I have superadded bacterial infection, can I say you have been hearing about the one shot of microbiology also? Will bacteria have enzymes? Yes, no, maybe. You guys have to answer this. Will bacteria have enzymes? No, Ahmad, I have never taught in pre-medical. Fine. Yes, for sure, right? If bacterial enzymes, bacteria will have enzymes, that's what is going to destroy them, right? So when I have ischemia and superadded infections, here I'll have excess of bacterial enzymes will be there. So here the main problem of destruction is enzymatic activation. Fine. Okay, it's enzymatic activation. So when it's become enzymatic activation, so what I see in microscope is liquefactive necrosis. Since liquefaction is more here, I am going to have liquefactive necrosis in case of a wet gangrene. The same example of the banana, since the bacteria is too much in number because they are dividing a lot faster, that's why superadded. 10 bacteria will also have enzymes.